Okay, so I'm going to be talking about treating disease and inducing rejuvenation with NaNots, which are the injectable nanotherapeutic for depleting pathogenic soluble targets. I'm Lou Hawthorne. I'm the CEO of NaNotics, the founder of the company, and also the inventor of the technology that I'm going to describe for you. And I want to thank Frank and Michael for inviting me back. I presented in 2022 as well. So what's new since 2022? Well, we have new efficacy data in cancer in humanized mice treated with NaNots. We have a new preclinical study in process in MS. We have new patents. We now have 32 granted or allowed patents, up from 15 in 2022. We also have a new Gen 3 NaNot that's now patented and in design. And we have been working on our information design just because the tech is complicated, so we're trying to make it easier to understand. So with that in mind, disease research and drug development has historically been very cell-centric. Existing drugs are mainly antibodies targeting cell surface receptors, or they're small molecules designed to enter cells. However, soluble factors, meaning dissolved in blood, are often direct mediators of disease and thus more relevant targets than cells. And these soluble factors are often elevated during disease, causally driving disease, and they circulate throughout the body. Depleting pathogenic soluble factors can actually reset dysregulated biology, including inside cells. So in other words, taking something out of blood, not targeting cells directly, can profoundly remodel a cellular microenvironment at the tissue and organ level as well. So arguably, the role of the soluble proteome in health and disease is of comparable significance to that of cells. However, the existing drugs are poorly suited for soluble targets, whereas NaNots are purpose-built from the ground up specifically for soluble targets. So let's dig into the problem space a little bit more. So looking at antibody drugs, which really are the current standard, many targets in biology have both an essential membrane form and they also have a pathogenic soluble form. Now, these two targets are biochemically identical, and antibody drugs use chemistry to target, so they can't distinguish between these two target forms. You put the antibody in, it's going to bind and block the beneficial membrane form at the same time it's binding the pathogenic soluble form. And even the pathogenic soluble target binding isn't perfect either, because long drug half-life drives soluble target accumulation, reducing benefit. And here's the mechanism involved there. So antibody binding to a target is not permanent. There's an off rate and an on rate. The target's bouncing on and off the antibody. When you have a long circulating antibody, you end up with a lot of antibody with target bouncing on and off. And if you think about it, a certain reservoir of that target is off the antibody at any time and is bioactive. So you haven't really neutralized the target with an antibody drug. You've stabilized it and built a reservoir of it. Bottom line, this drug class has limited benefit and potential toxicity. So contrast that with NaNots, which are designed specifically to distinguish soluble versus membrane forms. The problem space is the same, a membrane form and a soluble target form that are biochemically identical. The difference is the NaNot adsorbs, captures the soluble target, but it's shielded in such a way that the capture agents cannot interact with the membrane form at all. So you don't disturb beneficial membrane signaling, and that opens up all sorts of possibilities in therapeutic design. NaNots and their targets are then cleared by macrophage phagocytosis, and the bottom line is maximal benefit with minimal toxicity. So how do we do that? Well, we start with a core. The current generation is made of silica, which is fundamentally non-toxic. It's a structural element upon which we build. It's biodegradable and completely scalable. Onto that, we attach capture agents. We can use any molecule with target affinity. We're transitioning to nanobodies from antibodies. Then we attach a porous shield. The soluble targets diffuse through the shield, but the shield prevents the capture agent from having any interaction at all with membrane targets. And finally, we attach a stealth coating so we can control how long it circulates, just to delay immune recognition and clearance until the capture process is complete. It ends up being 150 nanometers across. You inject it like a drug, but it's cleared naturally by macrophages. It's essentially a programmable molecular sponge, or you can think of it as molecular apheresis. And we build it using click chemistry, which is modular chemistry, very easy to iterate, won the Nobel Prize in 2022. So this platform, even though we're preclinical, the platform is already validated and generalizable. We can engineer nanots against virtually any pathogenic soluble protein. And again, although we're preclinical, the binding kinetics are now confirmed in multiple rodent models. The kinetics are not going to be different in humans. Humans are just a larger volume of blood. You have to choose your targets right to get the efficacy you want, but the kinetics are the same as you scale up the dosing. So we've made dozens of research-grade nanots using antibodies. They've been fabricated against 4 different soluble targets so far. We've demonstrated that nanots against soluble TNF-alpha have shifted mortality in a simple mouse model of cytokine storm. We've demonstrated profound tumor suppression in humanized preclinical rodent models using nanots against 2 different types of tumor-generated immune inhibitors. We've also demonstrated ultra-rapid prototyping. The last 7 research nanots we made only took 4 months to engineer. And we've confirmed that the shielding, which is an essential feature of the nanot, works perfectly. So we're looking primarily at inflammatory diseases and cancer, but the nanots we're making have utility in longevity as well, which we'll get to. So to treat inflammatory and autoimmune diseases, those are known to be driven by a relatively small set of cytokines listed here. Likewise, tumors cannot survive without soluble immune inhibitors, a relatively small set listed here. The nanot chemistry is modular, so to change targets and diseases, all we have to do is swap out the capture agent. So for instance, to target soluble TNF receptors, which are an ubiquitous tumor defense mechanism, we put in an agent against soluble TNF-R1 and 2. It's a binary target. That depletes the target from circulation, which induces movement out of the microenvironment. They're fluidically connected. We create a diffusion sink. Likewise, if we want to deplete TNF-alpha from circulation, we just swap out the capture agent for an agent against TNF-alpha. And that captures and clears it from circulation. So I've mentioned 2 relative TNF targets, so I want to review. TNF is a tremendously important axis in biology, and it's one that we're really focused on. So let's review the 6 forms of TNF. So there's membrane TNF, which exists on the surface of multiple immune cells. That's the precursor to soluble TNF. Soluble TNF ligates one of 2 TNF receptors, TNF-R1, which transduces an inflammatory, sometimes apoptotic signal. This is how the immune system primarily clears out aberrant cells. But membrane TNF ligates a different receptor, TNF-R2, which transduces a suppressive or restorative signal. So note that the same cytokine is transducing 2 oppositional signals. One is inflammatory and one is suppressive or restorative. That's really interesting, and we're leveraging that in our therapeutic design. Both of the TNF receptors can cleave off under certain circumstances into a soluble form. They are then decoys, inhibitors of TNF. All solid tumor cancers cleave off their TNF receptors into a soluble form to inhibit incoming TNF. It's a fundamental immune evasion strategy that cancer employs. So these 3 soluble forms of the 6 forms of TNF are the targets of nanots under development, among other targets, but these are our first. So we're making a nanot against both STNF-R1 and 2 to treat cancer that has been successfully treated in the past by immunophoresis. I'll cover that tech in a minute. We're also going to expand that to all solid tumor cancers that secrete STNFRs. We think that's all cancers. We're also currently right now making a new nanot against STNF on our Gen 2 platform. This will be clinically used to treat rheumatoid arthritis, and this will be expanded to all refractory diseases normally treated with TNF-inhibiting drugs. TNF-inhibiting drugs are actually the largest drug class of all. It's about a $45 billion drug class. It's an imperfect drug class because they all reduce immune competence because they don't distinguish soluble pathogenic TNF from restorative membrane TNF. We're also going to take one of each of these targets and make a nanot against soluble TNF and soluble TNF-R1 to treat multiple sclerosis. And I'm going to get into exactly how these targets are key drivers in that disease. And eventually, we'll use this nanot for all diseases driven by soluble TNF for which membrane TNF is protective or restorative. These are foundational pathogenic targets, so a few targets that drive multiple diseases. That's always what we prioritize. And we have lots of white papers on these targets and diseases for those who are interested. But let's dig into STNFRs a little bit more. We know it's powerful to deplete STNFRs because there's already dramatic clinical data on the treatment of late-stage metastatic cancer via depletion of STNFRs by pheresis, which is extracorporeal blood filtration. Now, NaNots are a better way of doing this in every way, but it's still really helpful to have a predicate technology that shows us the power of depleting the very targets we're planning to deplete with NaNots. So there's a clinic in Bavaria. It's been shut down. The inventor had a stroke, but it ran for about a dozen years. I've been there several times, as have some of my colleagues. They treat cancer entirely via depletion of soluble TNF receptors, no other adjunctive treatments. And they treat them under a CE mark. These are patients who have already failed standard of care. They're terminal patients. And they've documented an overall response rate of 60%. That's unheard of for a treatment for a patient population this sick. Typical investigational new drug, checkpoint inhibitors, small molecule, ADCs, hard-pressed to go above 10% or 20% as the absolute asymptote. So 60% is a really phenomenal result. We actually went back to the historical data for Keytruda when it was in phase 1 to compare it with STNFR depletion, and this is what it looks like. So Merck did a 30-patient study. They documented a complete response of 6%, that's essentially remission, and an ORR of 16%. Compare that with 23% CR and 60% ORR for STNFR depletion. And Merck actually stacked the deck as well, because 8 of their 30 patients were melanoma or Merkel cell carcinoma patients. Those are notoriously immunogenic cancers. When you drop those cancers from the data set, the CR and the ORR for Keytruda go to 0. Whereas you drop those patients from the data set for STNFR depletion, and the CR and ORR essentially hold constant. Downsides of pheresis, of course, there's a whole slew of them. It's not really a commercially scalable approach. So NaNots are blazingly fast. They can deplete whatever soluble target they're programmed to deplete by greater than 95% in less than 5 minutes. Pheresis, by comparison, immune pheresis takes 3 to 4 hours to deplete the same targets by less than 70%. You might be asking, if STNFRs are such a fantastic target in oncology, why has nobody made a drug against them? STNFRs are an undruggable target because a drug against soluble TNF receptors would also bind and block membrane TNF receptors. That's a pathway that must be open for immunity to function. NaNots can deplete STNFRs without blocking membrane TNFRs. That's what they were engineered to do. So we've made NaNots against mouse STNFRs and tested them in a syngeneic mouse model of triple-negative breast cancer. NaNots induced 5 times the number of metastasis-free survivors as the control cohorts. NaNots against STNFRs induce tumoricidal immunity in metastatic triple-negative breast cancer. And we have a lot of transcriptomic data as well to support that. And we're moving this forward into human studies with Mass General under Keith Flaherty, who's kind of a legend of cancer immunotherapy development. Okay, so it's not on the TNF pathway, but we also made NaNots against a target on the PD-1, PD-L1 pathway, which is the largest oncology drug class. There's 7 approved drugs against either end of this. We made NaNots against the soluble form of the inhibitory ligand in collaboration with Mayo Clinic, and their team includes the co-discoverer of PD-L1. And NaNots against human soluble PD-L1 induced profound tumor suppression in humanized mice with triple-negative breast cancer. And that was, Mayo presented a poster at SITC, which is a big cancer conference in the fall. That's available online. And there's a publication being prepared for a top-tier journal right now. So I'm going to skip soluble TNF. It's kind of a no-brainer that we could make a best-in-class TNF inhibitor just by virtue of being specific to the soluble form. But I want to skip and talk about multiple sclerosis, because this is a true rejuvenation study, not just a disease treatment. So MS is a progressive, fatal neurodegenerative disease. It has a prevalence of 1 million in the US, 2.8 million worldwide. That's almost certainly an undercount. Very poor prognosis. There's no cure. And we've known for 30 years that it's driven by TNF. Yet, TNF-inhibiting drugs make it catastrophically worse. That's kind of baffling, right? We're going to talk about that. The commercial opportunity is significant as well. Okay, so it's helpful to look at homeostasis in the CNS. Why don't the rest of us, those of us who don't get MS, why don't we get MS? So in the CNS, there are inflammatory immune cells, and we're always subjected to a certain amount of soluble TNF in our CNS. It's a toxic process. It particularly affects ODG cells, oligodendroglial cells. They are responsible for maintaining the myelin, which is the lining of the axon. So it's like insulation on a wire. And it puts the ODG under stress. It can kill the ODG as well. However, there is a counterbalancing restorative process driven by membrane TNF. So astrocytes and other cells deliver membrane TNF to TNF receptor 2 on OPC cells. Those are the oligodendrocyte precursor cells, and they're responsible for maintaining the ODG cells. They can actually regenerate ODG cells. So you end up with this balance of ODG maintenance, so you don't lose your myelin. Now, in untreated MS disease, you have an uptick in soluble TNF both in the periphery and inside the CNS. This permeabilizes the blood-brain barrier. You end up with a significant amount of soluble TNF ligating TNF receptor 1 in your ODG cells, putting them under stress. The restorative process is interrupted as well by a second molecule, which is soluble TNF receptor 1, which is exactly one of the molecules that we're depleting in cancer as well. So what happens is it literally inserts itself between the membrane TNF and the TNF receptor 2 on the OPC cell and interrupts that neurorestorative signaling. Then the ODG cell is lost and the myelin demyelinates, which is the classic pathology associated with MS. So our intervention is pretty straightforward. We're going to put in 1 NaNot against soluble TNF. We will deplete that from circulation and induce migration out of the CNS due to their fluidic communication. And we'll do so without disturbing membrane TNF by virtue of the design of the NaNot. And the second NaNot we'll put in is against soluble TNF receptor 1. We've already made those for treating cancer anyway. We'll induce migration again out of the CNS, and this will restore the signaling between astrocytes and OPC cells and literally regenerate the ODG cells, which has been shown in transgenic studies to lead to remyelination and functional recovery. And when we deplete soluble TNF-R1, again, by virtue of the NaNot design, we'll not disturb membrane TNF-R1, which is a pathway that must be kept open for immunity and pathogen control. These are two outcomes that conventional pharmaceuticals cannot achieve. So, and this is just, I presented this in 2022. This is just showing that we've made NaNots against soluble TNF, and they work fine. We're actually looking for sponsors for this particular study. It's a $400,000 study. We've raised $150,000 so far. So there's a $250,000 balance. We're offering both equity in the company on the same terms as our existing bridge investors have received. Several of them are here, in fact. But we're also offering promotion and publications and presentations to the individual or group that provides the remaining funds. So how does this apply to longevity? This is Wang Deshun. He's a runway model at age 88. I mean, I hope I'm still modeling at 88. And I have to mention that in order to move from treating disease to treating longevity, we needed a new generation of NaNot. So we're on our Gen 2 NaNot, which works extremely well using click chemistry, has a good circulation time, it's very safe, very high repeatability. The Gen 1 we've retired. However, in moving to Gen 3, we want something that has no silica, that has a very long circulation time, and has very high repeatability. So we're moving to a surface-free NaNot that's all polymer. The downside of a surface is opsonization. Opsonization is when the immune system tags something for removal. Get rid of the surface, you greatly reduce opsonization. And the pure polymer design, silica is very safe, but it has a degradation rate. And if you eliminate silica, then you can suddenly start to think about dosing for the rest of your life to control aberrant signals. You really want a polymer NaNot for that. So this is our 32nd patent, and we needed to patent it before we start working with vendors, and that now is in process. So in terms of what we're going to do with this new NaNot, all-polymer NaNot, one of the things we want to do is tackle inflammaging. So inflammaging is the branch of gerontology that posits that not just age-related disease, but core mechanisms of aging are driven by inflammatory cytokines. These are well characterized. TNF-alpha, IL-1 beta, IL-6 are the big three. They're broadly pathogenic and poorly druggable, and there's, soluble TNF is right there, front and center. We're also very interested in endothelial barrier function. So it's known, so your endothelial cells line your vasculature. Vasculature goes everywhere in your body. If you have a dysfunction in endothelial barrier, you're going to have dysfunction in every organ and system in your body, which is characteristic of age-related decline. We know the three molecules that drive it. They're well characterized in the literature: CCL11, also known as eotaxin, CXCL9, these are both chemokines, and acid sphingomyelinase. They all reduce endothelial barrier integrity, leading to inappropriate trafficking of molecules either from circulation into tissue or from tissue into circulation. And when you put these molecules into young animals, it recapitulates the pathologies of aging pretty consistently in all the organ systems. This is an example of convergent pathogenic biology, multiple targets converging on the same type of degradation, and that's particularly interesting to us. So we have a great team. Our CTO, who's guiding development of the NaNot generations and is also our IP genius, is here, John, so say hello to him, and I'll take some questions. Thank you very much.